name's Kate Fetterplace, and I'll be talking about what are the energy requirements for my patients. I'm a clinical dietitian at Royal Melbourne Hospital and working in the ICU. This talk does follow on nicely from all the conversation that we've already had this morning. So hopefully we won't double up too much, but hopefully give you some more insights into understanding what the requirements are for your patients. These are my conflicts of interest. So what we'll cover today is understanding what the guidelines are recommending in regards to energy requirements for critically ill patients, understand how to estimate energy requirements and what some of the limitations are with estimated energy requirements, understand the role of indirect calorimetry to establish energy requirements. And we're not going to go into the detail on how indirect calorimetry works, as you'll cover that in the workshop. And I will touch on some of the evidence to support the current guideline recommendations as well, and some of the conversation that we've already had this morning. So energy requirements often form the goal for our nutrition delivery. And I suppose it is really important to think about this in terms of when we're estimating the requirements and then determining how much energy and how much nutrition we're going to deliver, we're actually delivering a lot more than just energy. And so we really need to think about that, because we are limited by the composition of the formula and then therefore what else we deliver at the same time as delivering the energy to our patients. So I think just take that into consideration, and we'll try and understand why we estimate requirements as we do, but what else we're delivering when we're providing nutrition. And Leanne will touch on protein, which we've already talked a little bit about this morning. The first thing to also consider is that not all our patients are the same. And Emma touched on this, that the patients that are admitted to the ICU will all be different. The degree of malnutrition is important, and that will change the energy requirements for our patients, and also change how aggressive we might need to be with the nutrition support. If a patient is obese, again, that will significantly change nutrition provision. And to date, we don't have a lot of data on individual cohorts within the ICU, because we often study everyone together. And so the evidence that we have really relates to ICU patients in general, and not necessarily these specific cohorts. So it is really important when you're seeing your patients in the ICU that you look at each individual patient and consider their nutritional risk when trying to determine their energy requirements and what nutrition you're going to provide. Emma's already spoken about the phases of critical illness, and I'm not going to go through this in detail. However, just to point out again that throughout the ICU admission, the energy requirements and how much we should be providing our patients will change. And the thought is that early in the ICU, the energy requirements, or what we should be providing at least, should be less due to that adaptation of the body and the endogenous production of glucose. And so these will change throughout the ICU stay. And so we need to be aware of this and reconsider what nutrition we are providing to our patients throughout the ICU stay. And reassessing our patients as they remain in the ICU is very important, as well as then onto the ward. The nutrition requirements will change once the patients are increasing their rehabilitation. And therefore we should be adjusting their nutrition delivery as they change. So what do the current guidelines recommend in regards to energy provision to our critically ill patients? So the two most prominent guidelines, the European guidelines and the American guidelines, these have been updated fairly recently, although the American guidelines now are starting to get a little bit outdated from 2016. But both guidelines are recommending that indirect calorimetry should be used to assess energy requirements. And this should be used because it can measure the energy expenditure, and therefore it can provide information on how that energy expenditure is changing over time. However, it won't give you any information about endogenous production of glucose and that body adaptation. And so even if you're providing nutrition according to indirect calorimetry, you could still be overdoing it in the early phases of the ICU. Both guidelines do recommend that if indirect calorimetry isn't available, and we know that it is hard to get access to in the ICU, that we can use predictive equations. The European guidelines have become more conservative and recommend that 20 to 25 kilocalories per kilogram per day is recommended, and particularly in the early phases that only 20 kilocalories per kilogram per day would be recommended. There's various recommendations within these guidelines, so I've just pulled a couple out here for you on the screen. And just to highlight really regarding the European guidelines, they're recommending that early in the ICU stay that only 70% of indirect calorimetry measures should be provided, or if estimated requirements, only 70% should be provided early in the ICU stay. In regards to obese patients, this is where we have much less data. And so there's much more controversy around how much energy provision we should be giving to these patients. And this is covered off in the American guidelines as well. And they recommend that in obese patients that we could use an equation such as 11 to 14 kilocalories per kilogram per day of actual body weight in obese patients. Again, I'd just like to highlight that really this is based on very low levels of evidence. And in this group of patients, we really need to understand better around what amount of energy we need to provide these patients. So when we're estimating requirements, we need to consider what weight we're going to use. And it is highly recommended that if a patient is overweight, that we use an ideal body weight, as if we use their actual weight, you're going to overestimate the energy that these patients are requiring. For obese patients, unlike the American guidelines, you can use an adjusted body weight where you use 25% of their obese weight. So that's their actual weight minus the ideal body weight according to their BMI, and add that onto their ideal body weight. And this is used to try and estimate what their lean body mass might be contributing to their energy expenditure. You can see it is fairly inaccurate, most likely. There's many estimating equations. Many of these date back to very early days of study. And so they probably don't relate that likely to our critically ill patients that are currently in the ICU. And so there's a significant amount of limitations when trying to use these estimated requirements. The most basic of these is the weight-based equations, which are recommended in the guidelines. So that's the 20 to 25 or 25 to 30 kilocalories per kilogram per day. In Australia, as dietitians, we use the Schofield equation, but that does date back to 1985, and it was actually investigated on healthy subjects, young males. So therefore, trying to extrapolate that to ICU patients is quite difficult. We know that these equations are very inaccurate, and the weight-based equations are the most inaccurate of all of the estimated requirements. In this systematic review, they demonstrated that the estimating equations underestimated energy expenditure in 60% of cases and actually overestimated energy expenditure in about 20% of cases. So it is really problematic when we're trying to use this in the ICU, and particularly, as I mentioned, the weight-based equations are the most inaccurate of all equations in estimating energy expenditure. Emma Ridley led this study in looking at a systematic review to try and assess whether meeting full predicted energy requirements improves outcomes. And they found that there was no difference. There was about 10 trials included in this systematic review with over 3,000 patients, and providing full energy as per the predicted equations didn't improve the outcomes of patients. And this was further demonstrated in the target trial that many of the faculty were involved in. And this was the largest nutrition randomized control trial in ICU with nearly 4,000 patients, which the patients were either randomized to receive a 1 cal per mil formula or a 1.5 cal per mil formula at a rate of 1 mil per kilogram per ideal body weight per day. What happened in the study is that energy was provided almost 30 kilocalories per kilogram per day in the intervention group, compared to nearly 20 kilocalories per kilogram per day in the standard care group. There was a significant difference in energy provision between the two groups, and the patients received 1.1 grams of protein per kilogram per day. So this study provided 70% versus 100% of energy provision based on that estimated requirements. And they found that there was no difference in outcomes, including mortality, ventilator-free days, and any of the functional outcomes. I suppose the key points to highlight with this study is that it was a relatively short-term energy provision of a mean of 6 days. And so again, it was only really looking at that really early phase of ICU, and feeding on average was only for around 4 days. So I think we can sort of take from this study that within that first week, providing 100% of predicted requirements versus 70 didn't make a difference to these patients. However, we're not sure what would have happened over a longer period, and also to highlight that the standard care group actually received very good nutrition, meeting 70%, which is actually in line with the current international guidelines, the European guidelines that I've already talked about. So I think, even the standard care group received quite good nutrition, and it was fairly short term based on predicted requirements, and there was no difference in the outcomes. So looking a bit further into indirect calorimetry, and if we provide nutrition as per indirect calorimetry, which is what the guidelines are recommending, does this actually improve our outcomes? So this is just some observational data around that I've collected on indirect calorimetry in patients in ICU. And I just wanted to highlight a little bit about their mean energy requirements that were assessed. Early in the ICU phase, I actually found that the patient's energy expenditure was quite low, only 22 kilocalories per kilogram per day on average. And through to day 5 being increasing up to 25 kilocalories per kilogram per day. But you can see from this table that also there was significant range in patients. And so highlighting that not all patients were the same, and that some patients had very high energy expenditures and others had very low. So on average, we're giving them around 25 kilocalories per kilogram per day as per the guidelines, but that would be significantly low for some patients, or potentially significantly high for others. And therefore, this is probably contributing to some mixed results. We do know that a caloric deficit is associated with muscle wastage and ICU-acquired weakness, and I demonstrated this in another observational study, although this hasn't really been proven with randomized controlled trials at this phase. So in terms of this question, does energy delivery via indirect calorimetry improve outcomes? The most recent systematic review was published this year by Dunn and colleagues, and they included studies that were looking at critically ill patients who required mechanical ventilation that were randomized up till the end of 2020. And the studies that were included used indirect calorimetry to guide nutrition therapy as the intervention, and used predictive equations to guide nutrition therapy as the comparator. So there's been 8 studies that were identified that were included in this systematic review, and that included only 991 patients. So you can see that there's still very limited data to actually determine the answer to this question. So what did they find? Based on meta-analysis, they found that there was a reduction in mortality when energy was provided according to indirect calorimetry, as you can see. One of the key studies that were included in this systematic review, and was really about half of the patients that were included in the systematic review, was this study by Pierre Singer and colleagues, the TICOS study. This was the phase 3 multi-centre trial. So Andrew did put up the pilot study results previously. With this study, they plan to include 580 patients. However, unfortunately, they stopped the study after 6 years because of the difficulties with recruitment, which really highlights the challenges with trying to use indirect calorimetry within the ICU. And so they included 417 patients over the 6 years. All the patients were mechanically ventilated, and the intervention was that nutrition support was to meet 80 to 100% of energy requirements guided by indirect calorimetry, and they used supplemental parenteral nutrition where patients were not meeting their requirements. And the control group received 20 to 25 kilocalories per kilogram per day ideal body weight. As you can see from this graph, there was a significant difference in energy provision between the two groups. So the intervention group received almost 2,000 calories, and the control group received 1,300 calories. There was a significant difference in mean daily energy balance. So there was a lot less calorie debt in the intervention group. And according to the Kaplan-Meier curve, you can see that there appears to be a separation between the two groups in terms of survival. However, this was not found to be a significant difference, and the study didn't meet its power calculations to find a difference. Also, the primary outcome in this study was infectious rates, which also weren't significantly different between the two groups, because in the original study, they did find a reduction in infections. So some of the key messages in regards to energy delivery is that there is evidence to support the use of indirect calorimetry to guide energy provision in critically ill patients. There is significant challenges with actually implementing this in the ICU. On our patients in ICU, we try and complete indirect calorimetry on patients who are going to stay within the ICU for more than 5 days. And we also target patients that are obese or underweight as a priority, or if they also have lots of complications that may be difficult to assess their energy requirements. So particularly those patients that may have come in with multi-trauma, or head injured patients are often ones that are going to stay, and therefore can be quite difficult to assess as well. And as Emma mentioned in her talk, that these patients often have a significant increase in their energy expenditure. We do need larger randomized control trials to really confirm the results regarding energy delivery in relation to indirect calorimetry. And when we don't have access to indirect calorimetry, well, what should we really do? And I suppose we can use these basic equations of 25 to 30 kilocalories per kilogram per day. But we do need to really consider that these might be very inaccurate, and we need to monitor our patients and assess what we're actually delivering compared to what our requirements are, and whether they may need to change over the ICU stay. Early in the ICU stay, it's probably reasonable to go lower than the 25, probably around 20, but we're done with caution, because if we are providing a lot less energy requirement, they're not delivering that, then we are risking underfeeding our patients as well. So we should adjust the requirements quite quickly. And just to, the last point is just monitor your patients and really try and consider when you need to change the requirements and change what you're doing.